everyone. Are you ready for our last panel of the day? So, excellent, excellent. You've got some caffeine in you. You're still with us. So we've got a panel starting now, and then we'll have our closing, and we'll be wrapping up about 4:30. So I'm just going to introduce, I'm going to point out here Shannon from Visual Talks. Shannon is our graphic recorder, and will be graphically recording the talk today. And then we have this amazing panel here, and I'm going to introduce Liam, who is going to be moderating the talk today. I'll pass it to you now, Liam. Thank you.
Hi, everyone. Can you hear me all right? Okay, great. Thanks for joining us for the last panel of the day. So first, I'll just introduce our panelists. So first, we have over here in the red, Matt Johnson, who is harm reduction worker at Parkdale Queen West Community Health Center here in Toronto. We have Gillian at the end over there, who is Gillian Kolla, who is a postdoctoral researcher at the Canadian Institute for Substance Use Research at University of Victoria. We have Steve Andrews, who may join us a little bit late, who is a harm reduction worker at Somerset West Community Health Center in Ottawa. So he might join us momentarily. And just to my right here, we have Dr. Claire Bodkin, who is a safer supply provider with HAMSMaRT, and maybe you can tell us what that acronym is.
The Hamilton Social Medicine Response Team.
Thank you. And two people over, we have Marlene Haines, who is a PhD candidate at University of Ottawa, also previously a safer supply RN at Ottawa Inner City Health. So if I've forgotten anything or anything you want to add, please do. I'll introduce myself briefly. So I've been a harm reduction worker for the last 10 or 15 years, Montreal and Toronto, including at Parkdale Queen West, where I was involved in some of the early implementation of the Safe Supply program there. And right now I am a PhD student doing research on health barriers, healthcare access, and criminalization. So yeah, I guess the intention of the panel today, the future of safe supply, I think for all of us, no matter what kind of role we play or how we're coming to safe supply, can often feel like we're really far behind of where we need to be. We've been locked into kind of reacting to compounding crises for a number of years now. And so the hope, I think, today is to kind of take a moment to get out of that kind of reactive tunnel vision that can kind of be created by that urgency and crisis, and look forward, think about what safe supply needs to look like, not just in terms of scale, but not just in terms of substances, but also in terms of a model that goes beyond the kind of punitive and paternalizing restrictions that we're often familiar with in terms of healthcare with people who use drugs, and in terms of ownership and leadership of people who use drugs as well. So hoping that we can kind of keep that in mind as we discuss things today. So kind of the first set of questions we were hoping to get started with was really about adapting to a changing supply. I don't think I need to tell anyone in this room, a lot of the safer supply initiatives that we've seen expand over the last few years is really in response to the kind of growing toxicity of the illicit supply. So let's just jump in right there and start there. We've seen kind of not only the saturation of the market of down with fentanyl, but also waves of high potency opioids like carfentanil, normalization of benzos in the supply, just to name a few of those dynamics. So Marlene, I'm hoping you can start us off on this if you're up for it. There's been some conversation about how to deal with the fact that benzos, for instance, have become a mainstay in the supply and seem like they're here to stay, at least for the medium term, but still those conversations are pretty marginal. So how can or should programs adapt to a changing supply? Whether the implications of that are in terms of an increase in tolerance or new substances. So take that whatever direction you'd like to.
Yeah, absolutely. Hi, everyone. So I had the great privilege of overseeing a safer supply program for the past 2 years, and just last week stepped back into more of a research role. Definitely in my time kind of working with the clients, I worked in a shelter environment and that had a consumption site attached to it. So it wasn't like quite a clinic model. Yeah, it was a great program to work in, but definitely over the years that I worked there, I saw the ever-changing drug supply, as you all did too. And I think, it speaks to a lot of different things, like the need to be really adaptive and flexible. I know that's come up as a theme quite a bit today in a lot of different people's talks, but really thinking ahead and trying to be responsive and adaptive rather than kind of feeling like we're really behind the times. Currently we use Dilaudid primarily, but that's no comparison to the fentanyl that we're seeing and everything else. And I think it's it really speaks to the fact that we do need a lot of advocacy around getting access to things like injectable fentanyl, getting access to things like injectable heroin, diacetylmorphine, and really about suiting the needs of the community at any given time, and also being able to kind of pivot when needed, because in a few weeks it could be something else. With benzos in particular, it does make things quite challenging with reversing overdoses. I know that kind of came up when we were chatting about it, and because of course, as everyone knows, Narcan is not going to be effective for benzos, and so kind of parsing out what's fentanyl, what's carfentanil, what's benzos is definitely tricky. But it also speaks to the need for a benzo safe supply, and again, that's just about kind of being adaptable and flexible and trying to not be 10 years behind in the things that we're doing and the things that we're offering. And I think that it's also recognizing that safe supply is just one small piece of what needs to be done. It's a really, really important piece, but there's a lot of big overarching systems change that needs to happen. As all of you do, I bore witness to a lot of systemic violence that would happen to the clients, and no matter what kind of substances I had to offer them, that systemic violence continuously beat people down and really undermined a lot of progress towards goals and things that they wanted in their life. And so I think it also speaks to kind of the bigger gaps in care that exist right now.
Gillian, I'm kind of curious if maybe to expand a little bit on the conversation around evidence that we were having at the beginning of the day. Where does this kind of need for flexibility, adaptation, responsiveness put us when there's quote unquote no evidence base to inform kind of adaptations to practice, for instance, to substances that might be newly introduced to the drug supply? So I'm thinking partly here about the critique level that safe supply programs often for more traditional, I'm trying to take this off, sorry, addictions medicine sectors around, there not being a substantial enough quote unquote evidence base for safe supply. So how does that jive, I guess, with,
Yeah. Well, I think it depends on what we actually value as evidence. Like there's not just one way to make evidence. Medicalized models tend to really, really value randomized control trials, RCTs. Those are very good for answering certain questions, but that's not the only way that we can make evidence. And I think that one of the important things about safer supply is, and a lot of harm reduction interventions, is that we actually really need to listen to the expertise of the people who have firsthand lived experience on these questions. So, I've always kind of questioned the idea that safer supply was not evidence-based. I think that we had very strong models around the delivery of other forms of opioids like methadone and Suboxone. We knew what was working, we knew what was not working, because people who use drugs have been telling us very, very clearly for several years what is not working about methadone models. The problem was we just weren't listening. And so I think that there's a question of valuation of evidence, who we listen to, who we take seriously. I think that also, and I think here, the COVID pandemic, what do I need to keep doing? What do I need to do differently? Okay. I think that what the COVID pandemic also showed us is that when we need to, because it's a public health emergency, we can move quickly. And we can really change the system. We can put in place new regulations. We can do things very, very differently if we need to, because it's an emergency situation. The problem is we've never looked at the overdose crisis as the true emergency situation that it is. We've never tried to move the mountains that we did, especially early in the COVID pandemic. Now we're in the kind of like denialist phase. But early on, I mean, and I think the really, really good example of this early in the COVID pandemic was around methadone regulations. We actually saw a loosening of methadone regulations early in the COVID pandemic that people had been calling for 40 years, but it was always said, oh, we don't have evidence to justify that, the risk is too great. Well, all of a sudden COVID hit, we loosened the regulations around methadone, and then researchers and the people who did this, I give them their due credit, they really, really quickly adapted to measure what happened when we loosened methadone prescription or methadone regulations. Well, what happened? We retained more people in methadone, and there wasn't any increase in harms that we could measure. And so I think that it's really, really important to think about wow, look, people who use drugs have been telling us this all along. When we actually did it because the need was there, we found out that they were right. And this is the important part, we're now stepping backwards, right? Most of those changes that happened, the loosening of regulations that happened, people now are moving them back in place in their methadone practices. And so I think we really do need to both be willing to widen what we consider to be expertise and opinion and evidence, but we also need to really learn and put those things into practice when we do figure them out. And I'm not really sure that we're learning our lessons. It feels a lot like we're going one step forward and 3 steps back.
Thanks. Matt and Claire, you both work in kind of clinical settings or in direct service settings. I'm wondering, how have you seen programs adapt to those rapid fluctuations or changes in the supply, and how could they be adapting better?
You want to go? You want me to? Okay. So actually, one of the things that's exciting about being here today, we've really been grappling. So our program is new. I just started in January, although Tim, one of our other prescribers, has been doing this for about 3 years. But stimulant safe supply has come up time and time again. It's not something that we're currently offering. And I was chatting with a colleague from Ottawa today who said, oh yeah, we've started doing stimulant safe supply prescribing, and we're developing protocols and keeping an eye on what's happening. So I think, I guess the big things, it seems like common themes today are stimulant safe supply, and it's exciting to hear that there are places that are doing it, that are being brave and putting the time in and figuring that out so the rest of us can learn. And then the other thing is things that people can smoke, right? It's just, there's such a dearth, and it is a formulary issue. Not entirely, but the SAFER program in Victoria has some smokable options that are not on formulary here and are prohibitively expensive. So I think it is very easy for all of us, well, maybe I shouldn't say all of us, it's very easy for me, and I think a lot of people, to get sucked into the emergency frontline crisis in front of us all of the time, and we do need to make sure that we are carving out that time to work in solidarity with people who use drugs around the policy pieces, whether that's what's on formulary or what options are available legally so that people can access the substances that they actually need. But the big gaps I see that I think I've heard from lots of other folks are those two. The benzo question is interesting. I don't personally know a ton of people who are intentionally using benzodiazepines. It seems to be more that people are using them unintentionally because it's in the supply and it's contaminated, which is a whole other question of how do you manage that, especially if somebody is using fentanyl sometimes and not at other times, and then at risk for seizures and withdrawal in that perspective. Stop there.
Yeah, I mean, I think I saw a lot of adaptation at the beginning of the COVID pandemic, and maybe not as much since. Is that better? Thank you very much. Most of my experience is in very well-established health centers that maybe have more resources and stuff. So I've seen people set up things like after-hours phone lines that pharmacies can call or people can call. So if there's been some kind of problem with their prescription, which is always going to happen, or the pharmacy messes up or something, there's actually somewhere to call. And I feel like this is going to be this is going to be unpopular with prescribers maybe, but if I go on Safe Supply, then you take over the place of my drug dealer. And just like I would be incredibly mad if I was calling my dealer and they were refusing to pick up the phone because I rely on you for my well-being and my safety, you need to be able to be there to cover for me. And so even if it's my fault and I don't show up, having systems in place to cover those prescriptions, to have things sent into other pharmacies, or to have prescriptions called into the pharmacy, even if somebody didn't show up to their appointment, all of that stuff becomes incredibly important. So having these after-hours lines where there's a doctor on call, I think are incredibly important, and one of the best adaptations I think I've seen to the programs since they started.
Thanks. So just kind of elaborating on this discussion around substances and what kinds of things we need to keep our eyes on. I guess I'm curious, just in terms of practice right now, I mean, there's, I think, a lot of adaptation that's needed to be done in terms of just managing benzodiazepine overdose, in SCS contexts and in community, and but also there's the issue of managing kind of benzodiazepine withdrawal for people who are looking to transition off of street supply or an illicit supply. So I'm just wondering if Claire or anyone else has any thoughts on that, around what clinicians need to be attentive to in that respect.
So I think this is one of the rare circumstances where the urine drug screen might actually be useful. So if people are not intentionally taking benzodiazepines, the urine drug screen can help us to understand what is in there, like what they're actually consuming. With the limitations, I'll put in a plug for the Safe Supply Community of Practice is running a webinar on urine drug screens later this month, maybe, or yeah, okay. So there are lots of nuances, lots of limitations there, but it is useful to try and understand what a particular person is using. And then also, as you're assessing them for withdrawal, to ask about benzodiazepine withdrawal symptoms, which certainly overlap, but are important to ask about as well in terms of like tremor and anxiety and some other specific things. And then we do need to be using I personally use a fixed dose diazepam taper, but there are different options, but we do need to actually be prescribing benzodiazepines when people are withdrawing from a benzodiazepine contaminated supply. I think the challenge that I would be curious if anybody else has a better answer to than me is when people are either really sure that they're not using benzos, and then we get into these scary situations where people are seizing, or where somebody is really intermittently using fentanyl and it's off and on benzodiazepines a lot, and I certainly struggle more in those situations.
Awesome, thanks for that. Gillian, did you want to?
Can I just follow up on something on that?
Yeah, briefly.
I think we have to name the elephant in the room here, and prescribers are scared. Yeah. If you had somebody who was having really bad side effects from their birth control, you try out a different kind of birth control. You have somebody who's having side effects from another form of prescribed medications, you experiment a little bit. And as Andrea mentioned this morning, we have the really, really visceral experience of people having been sent to the CPSO. And so I think that we have to get to a point where we can make an environment, we have to all work together to try to support prescribers. I'm usually harping on, we need to center the voices of people who use drugs, but I do think we have to take seriously the fear that prescribers do feel sometimes and figure out how we can support people to be innovative and to feel like they can experiment. We're gonna have a really fucked up drug supply for a long time here. There's xylazine in there, there's nitazines in there. We don't actually know what we're doing. And I think that is why we need to be able to be nimble and to be experimenting and to be following people's lead. And that's really, really hard to do when you have this fear hanging over you that you might be getting a phone call from the college. And so I think that, this is where as researchers, I think we're trying really hard to create the evidence that might make that a little bit of a safer environment. But I think we all have to figure out how we can work together in community to lessen that fear so that people can do the innovation that actually leads medicine oftentimes and leads new prescribing practices.
Thanks for that. That's actually, if I could just jump in just for the sake of time, because that's a great segue. Thank you, Gillian. To the next chunk of questions I had for all of you, which is just around the future of the medical or prescriber model. That's been the focus of a lot of conversations here today, and we will talk about other models as well, but just I wanted to spend some time talking kind of about the strengths and limits of that, and where do we see that in a broader safe supply response and a safer supply movement. So maybe Matt, you can start us off here if you're up for it. But with the known limitations of a model that we are all experiencing and living through right now, in terms of a model based very constrained by medical practice and the regulatory context that goes along with that, what do you see as the future of safe supply in terms of the prescriber model? What have you seen work well, less well?
Sure. So, sorry, just for context, I'm a harm reduction worker, but I'm also on safe supply. So I'm going to be talking about like personal experience of safe supply. Also, I'm sweating underneath my mask and fogging up my glasses. And for some reason, I'm drinking hot tea, which is not helping. So I'm just a little damp. I think, I'm a big proponent for like a public health model, or like a non-prescriber model, or like a buyer's club model, or something that's owned by us as opposed to owned by the system. But I think that we really need a medical system as well. I think what keeps coming out of these things is like options, or like the more options the better, right? And there's some real benefits to having a medical model. I'm in a medical model, so my GP is my prescriber. Unfortunately, when I first went on safe supply, this person had been my methadone prescriber for many years, and when I came to them and I said I demand to switch to at least long-acting methadone, long-release methadone, they refused, and I had to switch to a different doctor, and then they left, and they coached my old GP on how to do this, and then now I'm back with my old GP, and they're doing this. So I think, again, the lack of nimbleness and adaptability in the medical model kind of shows itself. But the benefits that I get are that I get these regular check-ins with my GP, so my health gets checked in with way, way more often than it normally would. And things that I would never book an appointment for, I end up talking to my doctor about. And because we have these regular check-ins, and because I've been with this person since I was like, I don't know, 22 or 24, like, this has been, almost 20 years I've been with this person, and so we've built up so much trust and so much of a relationship over time, and that can't be replaced, right? So I think it's like sort of the access that you can get, and things like that, but definitely some changes need to be made, because there are people who, it is great, and you can display to people that you get all these options, but it's also intimidating to walk into those medical models, especially to try to start off where you know that you're going to be drug screened, you know that you're going to have these very frank conversations about your substance use as somebody who doesn't do drugs, and somebody who historically has been part of the system that stigmatized you. And so I think medical models also need to put some more thought into like, how do we destigmatize this medical model that we have? And then, again, just like going back to what I said before, is like, if I'm going to rely on you, you can't be a fall down, right? And so, because this is my well-being and my safety, I rely on you for everything. And so it's this really like kind of sacred trust between somebody like me and my prescriber, where it's like, I need you to be there to back me up if things fall apart, right?
Marlene, I'm wondering if you can maybe jump in and elaborate a little bit on what your thoughts are, having had some experience working within a medicalized context around some of the limits there, and how do we, safer supply emerged in many ways in response to the failures and limitations of methadone regulatory models and related kind of clinical practices, whether that is about punitive carries policies or, painful restarts or what have you. So how do we, looking toward the future, how do we ensure that, safer supply, the mobilizing done by people who use drugs for safer supply doesn't kind of get folded into more dominant addiction medicine approaches?
Definitely. and that's part of a really common conversation that I would have with my team, was about really framing why we were doing what we were doing. And part of that, a big part of that is understanding that, you know, what we're doing is with safer supply is not part of an addictions medicine model, and that I know that lots of addictions doctors and prescribers have taken up safe supply and done a great job with it, but at the end of the day, safe supply is not based on the addictions medicine model of care. And in fact, they're very oppositional. They're very different, and it's really important to recognize how different they are. And so, yeah, I think that you touched on needing different models of care, and that's so important. I know in Ottawa we have kind of 3 very different models of care, and it works because it supports different people and their very individual needs depending on kind of where they're at. So the program I worked at was in a shelter, another program, larger program, was in a clinic setting, and another was at a community health center, and that worked kind of spread sort of across the city, and that really worked well because we definitely saw very different kind of populations and were able to offer care in the ways that people needed it and wanted it. But I mean, I definitely think we need to work to demedicalize safe supply. What exactly that looks like, I'm not sure, but leaving it in the hands of, I think, medicine or nurses like me or whatever else it might be, I don't think it will work completely in the long run. It can be a part of it, but it can't be all of it. And I just wanted to say too that I think part of this too is kind of envisioning for the future, but also doing what we can do today. So I have heard some people kind of use the excuse that they don't want to do safer supply because they don't believe in it, in the sense that they really do think it should be kind of owned by people who use drugs, and it should be only done through buyers clubs. And while definitely I'm in agreement with that, we also have people who are dying today, and so what we can offer today is what we can offer, while still looking to the future for kind of the models that we kind of seek and are hoping for. Yeah.
Thanks, Marlene. So we've just been joined by Steve Andrews. Steve is a harm reduction worker at Somerset West Community Health Centre in Ottawa. Thanks for joining us, Steve. Feel free to add anything to that intro if you'd like to. I'll let you catch your breath as well.
Okay, I'm a community worker, which is like a peer worker. So basically, like 90-something% of our, I hate saying with clients, these are my friends, my people, the people I've gotten into all kinds of shenanigans you don't want to know about. Anyways, and it's not like I've changed and I've given up certain ways, and I'm pretty much like, same guy, same habits, same things, same, I've just been very fortunate in the way things have, and to be fortunate enough to have my voice heard by people like you, who, like, it's something I just wasn't able to turn down. But
Steve, if I could,
yeah.
if you're up for it, I'm curious if you could share, because right now we're just talking about the future of the medical model or the prescriber model, because that's kind of one of the only models that we're working within right now. And I'm wondering what's worked well for you for that. What have you seen working well in the current model, and what have you seen working less well, if you have any thoughts on that?
I've seen some. Sorry. Yeah, I've seen some people respond well to the medical, like you're talking about the hydromorphone little fact is I was like the first one in Ottawa to be given that. Like I was like the guinea pig, and because we came to a convention here and got information and brought it back to our doctor, and he decided, and then it was really cool to be able to be honest with your doctor. Usually you want to do the opposite, right? But anyways, I lost my train of thought, but like, okay.
Yeah, no, just what else worked, what other elements, either in your experience or the people that you're working with, what's worked well, or maybe what remain hurdles, or what's worked less well in terms of relying on the prescriber as that gatekeeper?
Oh, yeah, that's a burden on the prescriber and the gatekeeper, as like some of them like are just like treated as a job. They're in for 9, they punch in, they're out for 5, they punch out. And if somebody dies, excuse me, I'm sorry, especially if there's kids here. If they punch out at 5:05, somebody overdoses at 5:06, and they made it to their car. Oh, thank God, I don't have to deal with that. But then we got nurse prescribers who like are bending heaven and earth to try to do everything to bring people back, and they're in it for the fight. They're just as invested in it as anybody struggling with it.
Cool. Thank you.
Yeah.
So we're just going to switch gears a little bit around discussions around the medical and prescriber model and speak a little bit to what a public health model might look like. So many folks have advocated for a public health approach to safer supply, recognizing the challenges that we've talked about around getting prescribers who are reluctant on board and the limits around scale up to meeting the kind of, I think, ocean of need that you referred to earlier, Steve, in conversations earlier. So what would this look like? Gillian, maybe you could start us off here. When we talk about a public health model or a kind of population health approach or kind of meeting safer supply and the overdose crisis with the same urgency, for instance, that we met the COVID-19 emergency, what would that look like? What are the kind of mechanisms that we need to lean on to make that happen?
Mm-hmm. Are we talking about an ideal world or the one we're actually living in?
Yeah, that's the thing.
Because, I think that we saw with COVID that when we need to move mountains, when we need to, change the structures, when we need to loosen regulations to keep people safe, we can do it. The issue is we just don't want to do it in this case. I think I'm going to have a bit of an editorial comment and then I'll come back to your question. I think we have to stop thinking that political parties and different political parties might save us. I've been doing a lot of work in BC in the last little while, and they have an NDP government there that has a very strong rhetoric around safer supply that's not backed up with any action. And I think in a certain place, it's actually easier to be working when you have a government that is completely opposed to you, because you can at least call out the bullshit really, really clearly. So it's not going to matter which government changes. We might get little incremental changes based on different political parties. I think if we want to build a public health model, we're going to have to build it ourselves. And I think that this is why people were so disappointed around decrim and the announcement around decrim. The problem with 2.5 grams as a threshold in BC is it basically makes compassion clubs or buyers club models very, very difficult for people who use drugs to implement themselves, because the threshold is so low. A higher threshold means you could actually start buying dope on the scale that you need to and be distributing it within community. And so I think we're at an interesting point, because we have a lot of different medicalized models right now that are being piloted in the Atlantic provinces, in Ontario and Quebec and BC. These models are actually quite different. And so we're going to have a really good evidence base very shortly around medicalized models and what works well in different circumstances for different people. Primary care delivery, community health center delivery, addiction medicine delivery, whether we're going to be taking, medications to people in parks, all of that kind of stuff. Christy Sutherland is now selling fentanyl. So I think that we have a bunch of these different models that we can start to look at the pros and cons. These are all within the medicalized model. And we need to start thinking about how we can support communities of people who use drugs to move outside. A public health model would look like we start setting up dispensaries where we have heroin and fentanyl, regulated products that people actually want and that they can come in and purchase. Like Matt was saying, we have to make it easier than people's drug sellers, because as much as we portray drug sellers as predatory, the fact of the matter is people who use drugs talk really nicely about getting a good drug seller. And when you've got a good drug seller, that's a really strong harm reduction mechanism, right? These are friends, they're people in community. And we have to stop demonizing them and actually start learning from them a little bit about what might work in terms of getting drugs to people, but we need to be better drugs. Thank you. But again, we need to start really thinking about how we can support communities, how we can support groups of people who use drugs. This is why the DELF model in Vancouver is really interesting. It's groups of people who use drugs who are just saying, get us more drugs and we can get them to people. We know who people are, we're in the community. And that's essentially what we need, and that's how we need to figure out what to do. Oh,
Sorry, we were.
Sorry.
no, it's okay. You might have something to add. I was pretty much at the end. Yeah, I think that we can embed this in drug users groups. Groups of drug users who are already out there, who are already organized. We start to figure out how to get them a regulated supply, and they can get it out to people, right? Dispensary models, buyers clubs models, that is very, very doable. But right now, there's the lack of political will, and like we just need people who are willing to take the risk.
Thanks. I think that also echoes some conversations we were having this morning around, in the first panel, around pushing back against the co-optation of community practices in ways that don't serve community, and actually resourcing those communities from the bottom up from the beginning. So thanks for underlining that. Steve, I'm wondering if you could speak to this, but I'm curious if, in your experience, you could speak to some reasons why people don't want to get on safe supply or don't want to get on methadone or OAT programs.
Because it's so much quicker to just phone up your
Yeah.
guy and have a hell of a lot more than 30 milligrams, which is going to do nothing, and be on a nice nod with $20 within 10 minutes where I come from,
And apart from that convenience factor, I'm wondering, a lot of folks that I've worked with over the years have had a lot of concerns around kind of that level of medical scrutiny and kind of meddling in their lives and that oversight, and concerns around health surveillance, particularly around. So I'm not sure if that's something you've experienced or you're seeing much.
Like they don't have it, just like none of the rest, like very few of the rest of us have it. They have it even less. They just know that, like, at this point, like, if they're, like, it used to be the problem was, like, pure fentanyl and its analogs were too potent for opiate addicts. And at this point, that's not the problem anymore. We've grown a habit. We have the tolerance. We can make, you know what I mean? Now it's the adulterants that are put in it. It's, you got flual bromazepam, you've got flual praza. I can't pronounce these things. And like I've done every benzo that has been marketed and prescribed on the market in Canada. I think probably I had a real problem with them, to the point where I had to rat myself out to my doctor and tell him, like, stop giving me these, like something bad's gonna happen. Anyways, that here nor there. But like when you see little kids that are experiencing within a year, like the kind of traumas and horrible things and this and that in 1 year that I had to, that it took me like 5 to 10 years to go through. It's scary, I mean, and then you got xylazine, which we haven't even spoken about, but it's coming. It's coming down the pipeline, and
So on that topic around, you're talking about that need for nimbleness and flexibility and adaptation, which other folks were speaking to earlier as well. But Matt, I'm wondering if I could pass to you, and if you have any thoughts around, how do we meaningfully address those concerns for people who don't want to enter into a highly surveillance system, people's need for discretion, fear of how this might very sensitive information around criminal engagement with criminal trades might be used by the criminal justice system, child welfare system, et cetera. So how do we, if the medical model is going to continue in some form for some time, and it's one of the few tools that we have at our disposal at the current moment, how do we bring those people in, or how do we address those concerns, or how do we make those adaptations?
Yeah, thanks. I mean, you mentioned the child welfare model, and I think that's obviously a huge fear for lots and lots of people, and an enormous barrier. And so we need to have some really clear programs in place that are very clear about providing safety for people, and that we won't rat you out to CAS or other things like that. I mean, one of the big barriers I see with people trying to access safe supply currently isn't even about prescribers, it's about pharmacies. Pharmacists, there are some great pharmacies out there, but most aren't. My pharmacy, even though I pick up my prescription there regularly, they won't stock my medication because they've been told not to stock opioids. So it means, they have to reorder it every time I show up, and so it causes these disruptions in my supply. And even if they get it to me by the date where like I don't miss a dose, the amount of stress I have around that is enormous, because again, this is like my safety, my well-being. Also, pharmacies are just not safe places to be like talking about some of these things, and some pharmacies have really like outed people and asked a lot of really intense questions. But why are you on this medication? This should only be for cancer pain, things like that. Then the formulary is great in that it covers you, but again, then information is being passed along to the government about what medications you're on. And if our ideal here is to try to like provide people with more support, if people ever want to come off the formulary, if people want to come off ODSP or OW, we don't have anything set up for people. So, lots of private plans will not cover safe supply. They don't even have safe supply in their language. And where they do cover these medications, they often have really intense restrictions on them. So lots of private plans have restrictions on how many methadone doses you can get in a year, or how many methadone doses you can get in a period of time. And they have that with Cadian as well, and Meslon, and a lot of these other medications. And clearly, it's about limiting how much they pay out for people, and assuming that most people who use drugs aren't going to go to their employer and say, hey, can you change our plan because it won't cover my safe supply medication for me. Yeah. So I think there's like a lot of things like that. And then I talked before about just like, it's intimidating to come speak to a fancy doctor about this stuff, especially because we've all been raised with it. Like Steve mentioned this, we've all been raised with the idea that like don't tell your doctor any of this stuff. And a lot of safe supply programs that I've seen seem to be taking on a bit more of like a methadone light model, where there's still like very regular in-person appointments required to get your medication, very regular urine screens that are required, and just like, you mentioned earlier the help that urine screens can have in figuring out what drugs you're taking, which I totally agree with, but just like the indignity of all of these jabs, like no other medication do you have to get piss tested so often, and that places that then monitor you when you're peeing, pharmacies that treat you so different for this, a lot of that stuff kind of just builds up and creates this whole weight that you have to bear, that you feel you're kind of tainted whenever you access this system, because everything is different for you and just a little bit more difficult and a little bit more shamey. So yeah, I think it's really important that programs kind of, like was mentioned before, like this is not the old methadone model. This is the antithesis of that, and that's going to be really important for the future.
I had a question about kind of related to that around best practices and standards, and Claire, maybe you can start us off if you're game, but in some ways safer supply movements and practice has involved this movement towards standardization, right? And part of that's around ensuring best practices, guidance to ensure quality of care, particularly for people who are new to prescribing, consistent evidence-based, all these factors. But again, people today and earlier today have been speaking to the need for flexibility and having multiple models, not only in a medical setting, but buyers clubs, et cetera. So how do we establish standards of practice without that becoming a constraint or limiting adaptation? And how do you navigate that, as a clinician?
So I think first I just want to acknowledge that the prescribers who were taken to the College of Physicians and Surgeons of Ontario, that could have gone a lot of different ways. I'm sure, I can only imagine, very stressful for them. But the outcome of that was that their college complaints didn't move forward, like they were dropped, but more importantly, the college in Ontario actually recognized safer supply prescribing as a practice that was legitimate to do as a physician. And I think that is pretty huge in terms of enabling people, like prescribers in Ontario or physician prescribers in that college, to be able to move forward. And it was more freeing than it was restricting. And we're people worked very hard to get it to that place, and there was like a certain element, I think, of luck as well that it landed how it did. I do think that we have the opportunity right now as a community, and that includes people who use drugs, that includes prescribers, that includes people in all sorts of different roles in these programs in medical models, to be part of establishing the standards, and not just like what they are, but what their flexibility is and how they're revisited and how they're created and who's at the table as they're created. And that's an opportunity that I think we all need to really seize together, so that we can create something that actually works for people instead of works against people, and that isn't just like a cover your ass sort of thing for prescribers and programs. So I think that the how we do it is actually more important than what specifically is embedded in it, and that if we get a good process, we will be able to then have these responsive and like, you know, person-centered approaches to prescribing. And if we're able to do that, you know, a lot of like the prescribing profession, so nurse practitioners and physicians, are self-regulating, right? We get judged based on, you know, what someone else with our training and experience and area of focus would do. And so if we can establish things that are flexible and that are built by people who use drugs and in a collaborative way and with that adaptability, then that is the standard that we're going to be judged on, and that's going to set us up to, I think, have the best possible medical model. So yeah, I think that's an opportunity we have, and I hope that together, with the support of the national community of practice, we're able to move in that direction together.
Thanks, Claire. Marlene, I don't know if you want to maybe elaborate on that. There was also a question that we're curious about putting to all of you around kind of collaboration across different health practices, which is kind of related to this, so feel free to take it in either direction.
Sure. Yeah, I wanted to say, I think that having like standards of practice can be really important, but I think it's also, it can be really dangerous, kind of like what kind of was said before, that if you kind of really narrow it down to, you know, this is the way you do a program, then you really risk, you know, not capturing and not actually having a program that will engage a lot of people. And so what I think is even more important, and something that I talked very, very often with my team about, was not so much about how do we run the program, but it was more about what are our ethics, what are our values, what is our philosophy of care? Because if you have that set in stone, you will be able to fall back on that each and every single time. Because with the ever-changing drug supply and with unique individuals in front of you, you will never always have the answer. It's not possible. And I think falling into those patterns of feeling like we know the answers, we have those really clear guidelines. Guidelines can definitely be useful, but also understanding that you have to be able to be ready for when the next thing comes up, that, you know, and be able to say, you know what, I don't actually know. I don't have an answer right now, but let's talk all together as a team. And I think that's really important. And so even things like the urine drug screens or weekly check-ins, really asking yourself, like, why do we do this? And our team in Ottawa did that and asked, like, why do we ask people to come in every week? Why do we ask people to hand in urine drug screens every week? Like, that is not okay. And so we ended up adapting and being flexible, and we ended up moving to a model where we did urine drug screens every 3 months, and it was a information gathering activity where it was really for the clients to be able to say, hey, we sent this off, here's what was in it. But, you know, if you look at a weekly kind of model and really look at it, like, why are you doing that? Is because you feel like you need to surveil and you are like looking into punishment, or, you know, can you move to a model that doesn't do that as much, that is more flexible and adaptable to the needs of people? And why do you need people to check in weekly with you? You know, I don't want to check in with my doctor every week. I don't want to check in with my doctor every month. So why do we make people do that? And I think that's really, really important. I guess that's what I got.
Thanks, Marlene. So we wanted to take the last 10 minutes or so of the panel. Oh, Matt, did you want to?
Yeah, do you mind if I just add something?
Yeah, maybe briefly.
I think one of the frustrating things for people who use drugs and who are on these programs is it seems like there's this huge amount of risk aversion when it comes to this. and this fear that's like, well, we have to make sure it's completely safe before we do anything, and this fear that like somebody's going to die off my prescription pad. But you know, when people had Hep C, we prescribed them interferon, even though it had huge amounts of side effects. We prescribe people chemotherapy when they have cancer, even though chemotherapy can straight up kill you. So, you know, other things, it's always like, well, is this less risky or less likely to kill somebody than the alternative? And although, yes, it's possible somebody could die off your prescription pad, they're for sure going to die not off your prescription pad. So no matter what you prescribe people, no matter how you prescribe to people, it's going to be safer than the street supply. And I totally understand why people are freaked out about losing their license, about losing their, you know, their ability to practice, all that stuff. What gets just so frustrating over time of doing this is that what we risk is death. We're risking our lives. And we've been asking, like, please care about us, please. Thanks. You know, please, don't kill us. And so in that balancing act, it doesn't feel weighted or fair. Although I do totally understand also.
Thank you, Matt. So in the last 7 minutes or so we have for the panel today, we wanted to turn the focus to the future of safer supply in terms of advocacy and activism and organizing. You know, safer supply has come from the demands and relentless organizing of communities of people who use drugs. I think when we were starting up the safer supply program at Parkdale Queen West a few years ago, it was around the same time that the province was trying to shut down OPS and SES, and I think a point that a lot of us who are working in those more formal healthcare settings were making, similar to points brought up earlier today, is that, you know, all of the harm reduction measures that we practice as a part of healthcare right now started off illegally, and that if we're not working in the gray areas of the law and the gray areas of regulation, we're not doing responsive healthcare for people who use drugs. And so I'm wondering, kind of in that spirit, how do we make sure that people who use drugs expertise and leadership is baked into our next steps? I think COVID really put a wrench in a lot of that engagement and participatory ethic that I think many of us tried to advocate in the early throughout, right? And that people are continuing to advocate around. So Steve, maybe you can start us off, right? Like what would be useful ways for people to plug into advocacy or activism or even program decision making, if you think about the programs that you've been involved with? What would be ways to get the broader community and maybe the people who aren't engaging with those as quote unquote clients, you know, participating in the decision making, right? And in the establishment of those programs. Do you have thoughts?
I like the question, actually. I like your question because like for years and years and years before this, I was known as Nodder Steve in Ottawa, like on the block. I was the guy that you would go to if you needed down, and like I'm not trying to get like this is people needed something, and I was there to, but fuck, it doesn't take long for me to lose my train of thought, but like for it to change to like say the last part of your question.
Like ways for people to plug in, ways for people to be a part of decision making, to bring in folks who aren't engaged into how the decisions around how these programs operate.
Okay, so for example, like the CHC I do some work at has many different like three, I guess, different programs that are directly directed to help people, homeless people who use toxic drugs, and like we do our best to make sure that like we don't, like horrible things don't happen. They do inevitably, but like, you know what I mean? But just like the fact that they're not just going to get their drink and their whatever, and like, which I couldn't have been bothered to do because I had, you know, like anybody who can come up with a few bucks, like has no need for 30 milligrams of methadone, like or whatever. But it's the bond you build with your prescriber, like if you find a prescriber you can talk to and be honest about, like honest about, I respect you for what you're giving me. Like you took a big chance, as my doctor did in the beginning. But unfortunately, I really thought it was going to work, but it's really disappointing. You know what I mean?
Yeah.
Like I just, anyways. So
Thanks,
I think
Steve.
that the only two futures of this I see is broad mass testing of people's substances before they use them. You know what I mean? So not like 2 weeks later, oh, by the way, a couple of weeks ago you used some shit that had xylazine in it. You don't even remember which one it was. And it probably isn't the same connector anymore. So
I'm just going to jump in, Steve, just because we only have a few minutes left, if that's all right. But I think you're really underscoring.
I told you.
No, all good.
I told you to jump in.
But I think you're underscoring the fact that, you know, there's this tension as we scale up. We need to keep our eye on quality of care. We need to keep our eye on making sure that time is structured in for quality relationships. So, Matt, I'm wondering if you could speak to where you see the future of advocacy around safe supply. How do we kind of, Carolyn Bennett spoke here this morning, and that's a kind of instructive case in point in terms of how, you know, despite our best efforts, a lot of our advocacy around decriminalization can get redirected into disappointing half measures. And so I'm wondering, how do we apply those lessons in terms of safe supply? And that's maybe an impossible question, but
Yeah, I think there's like a range of things. So some things that are like most easy to do is if you're seen as like an expert in this field because you're a prescriber or a researcher or whatever other professional you are, don't speak unless they will also include somebody who uses drugs or somebody who's lived experience on these things. So get more people involved in these kind of conferences where the networking happens. You know, Steve mentioned that he got on Safe Supply in Ottawa. He was the first person because of a conference like this. Like lots of stuff and networking and cool things happen behind the scenes when you get these groups of people together. And then I think we already have the models of how we can do this. So if you look at the success we had with OPSs and SCSs, I mean, that came out of Moss Park, that came out of this multidisciplinary volunteer group, and then in Ottawa, the same thing. And you can see it with Dulf now handing out drugs in the downtown east side. I think what we really need is that, again, people who use drugs are taking the risk all the time because they are picking up and dealing with their friends, or they are spotting for people, or they are doing whatever else. What we need is allies who are willing to step up and be courageous and be willing to be arrested or be willing to, sacrifice some of their freedom for our freedom, because I'm not the most impacted community anymore. Like, I've had a salary for many years and I've had a home for many years, but for the people who are most impacted, it's not, they're already being arrested and they're already dying. It's not fair to ask them to risk anymore. We need to come in and step up and take on some of the more risky roles to take it away from those folks so that they can be guiding us and involved in policy, but then other people step up to take up the most risky roles, like procuring off the dark web, holding stuff, handing it out, things like that.
Thanks so much, Matt. We're going to have to leave it here. So thanks so much to Gillian, Matt, Marlene, Claire, and Steve for your time and your wisdom. Thanks to everyone else.